Good afternoon, all of you. I hope you're having a great day. You know, 3 years ago, we wouldn't have suspected we could come and meet, right? So the kind of work we're presenting, it started where, everybody was worried, and like many of you, we did what we could do to help, right? Luckily for us, we were able to engage. And it sort of happened that a small team got built up, right? I still remember I got a call, I think from Dr. Ujjal, who retired recently, and he said, okay, they're trying to build a ventilator, and do you have any advice on supply chains? So Ujjal and I were there, and the best advice I thought I gave is don't try to make it just outsources. That was my 2 lines of contribution to that project, okay? But then, at the end of it, I said, okay, because I'm a person who works in operations and supply chains as a professor, then got us thinking and said, can we do something? Because all of us were worried, what is this thing? And we were all scared, wearing masks and distancing and things like that. So I asked a bunch of our faculty, hey, do you want to help? And all of these people that you see showed up, right? Some are still with us, some are in this room, right? And you won't believe it, for the first 1.5 years, we would meet every Tuesday, and we would talk about it. I think it was more like a cathartic moment for us, that we could talk over Zoom, and we would talk about things which we thought would help, right? And there were not just professors there. As you notice, there's a doctor who joined us, says, can I help? And then we had Ron, who of course you all know, and he didn't attend many of these meetings, but he would introduce us to nice problems. And then we have people who have left now and become professors at different places. They all just got together and we used to meet, you won't believe it, without taking attendance. As a professor, we don't, but they would show up. So over time, much of this work is reported on our GitHub page, and Ujjal and Bose will point to it. It turned out we did a lot of things, and now looking back, it looks as if we planned everything. Not at all. We didn't, right? It's just the way we are presenting. After 3 years, it feels good to talk about what we did and what we learned. I think most of the time we were trying to help, but we were also learning. I think what we learned is much more than how we help, right? So we have done, as a group, work on prediction, and I'll tell you why. We have done work on control, and we have done work on behavioral issues. These 3 turned out to be the 3 sort of important things to do, because obviously if you can't predict, we can't take action. Then the question is, what action is good? Should you shut down? Should you test more? Should you do both? And then eventually we realized that there are significant behavioral issues which we still do not understand, right? As you see, much of this work was motivated by Shield, and Marty spoke to you before lunch, after lunch. He also, at the end of it, looked at the behavioral issues. That people, a few students can make things worse for everybody by not following protocols, right? So these are 3 things I think are important. Let me give you a quick overview of some of the stuff we did, why prediction is difficult, and why we needed prediction, first of all, okay? So after this work on ventilators, we said, okay, can we, so testing became important, right? How many tests? And there was a shortage. Not the saliva part. Basically, they were trying to set up testing all over the place. And we said, look, how would you allocate test kits? And where should they be? Okay. What we realized, and Anton, who's sitting up there, he used to run these forecasts every week and saying what will be the infection next week, okay? We realized that allocation cannot be done without prediction, but there is a difficulty in making those predictions. And that's the one big lesson we learned from doing some of our work. And the problem really is that this was almost like, you have this groundhog and you whack a groundhog kind of a thing. You try to solve something here and the epidemic pops up somewhere else. And much of the issue was the asymptomatic transmission, but also the fact there is a very complex dynamics behind it, and more or less the fact that there is some spatial variation, right? So some of the issues we faced was complex spatial dependence, right? This long gestation period, which makes a reaction a difficult thing to do, okay? As Marty alluded in his talk, it's important to understand what are hotspots. And what we learned from prediction is, first of all, there is no one model which works very well, right? Secondly, the model that works well depends on the stage of the infection, actually. And thirdly, we learned that when there is very little data, if you can identify the way the disease is propagating, which itself was a big scientific challenge, right? Then you could use transfer learning and learn from other disease propagation, okay? One other idea we came up with was the idea that you could actually model the spatial dependence, and many countries did it later on, not because of our work. I think one thing, let me confess, and that's due to Bose. Much of the work we did, a lot of other people also did, okay? So all of us were sort of struggling to learn as a community, and there are people in India who realize that much of the infection is coming from a railway junction, which is not in the metropolitan city. So you could actually see when the disease is coming to Chennai, if you looked at the Dindivanam junction or something like that, because that's where a lot of people come, and if the disease is, is spiking there, it will eventually come to the metro, okay? So with that, we said, how do we model this? So some of the work we have done is on using neural networks with transfer learning, which is trying to predict not where the disease will be, but where it is coming. So maybe instead of, whacking the groundhog as he shows up or whatever, we whack it much before that, right? So that's what we learned, and Ujjal was kind enough to write a huge tutorial on it. We did a tutorial in one of our professional societies on prediction where we were talking about that, right? So prediction is something I think we understand a little bit, that we can use models, but we can use the models if we knew how the disease works, and that was, I think, the big learning point for me, right? If I knew what was happening, all of us could have done it much better. That's for the future, okay? Now, on the behavioral side, before I go and give the mic over to Ujjal, what I want to share with you today is two things. One, work on large-scale testing, which is what Marty also talked about, but we are going to talk about two things, especially the second part, which is Shield, Illinois testing data itself, which we use. That'll be very interesting, where the behavioral part shows up on the effectiveness of testing. And then Bose will talk about a theoretical model, which, all of us wondered, if we shut everything down, will the disease go away, right? So she's going to tell you when it is going to shut down and when it's not. I promise you, we have learned a lot, and we continue to work on the behavioral and long-term issue. So I'll introduce Ujjal.
Thank you, Sridhar. So my name is Ujjal, and I'll be presenting. So what we will be doing is we will present some snippets of what we have done, some of the work that we have done and some of the work that we are continuing to do now. So the first work, how do I move this? Okay, yeah. The first work that I'll present, and this is motivated by Shield, Illinois, and a lot of other universities, right? And when this closed down, and when we locked down, and we being professors, and I was teaching a class, and we moved online, and we were saying, how do you really safely reopen and have in-person classes amid the COVID-19? Right, so we kind of got motivated by the shield testing, and we said, okay, let's try to understand, first of all, theoretically, and then also practically, what are the combinations of policies that can lead to safe reopening. And it is not one policy, it is not just testing, it is testing, masking, social distancing, and so many other things, right? And what is the right combination? What is the right combination, right? That's what we try to understand. So we build this model. Now, when you talk of universities versus when you talk of these large populations, there's a big difference. In universities, we have, in UIUC, it's 50,000 students and faculty members and other staff. In other universities, it varies from 10,000 to anywhere between 50, 60,000. It's still a small population compared to the large population that you have. And the large population models, we can actually take an average of the population, and we can basically say that, okay, this is how the disease will diffuse over this population. But in a small population, we cannot say that. Individual behavior matters. Individuals' network of contacts matter. So the contact tracing and all these things matter in universities much more than large populations, right? So we built this model. We incorporated contact tracing, we incorporated testing, we incorporated external infections, we incorporated internal mobility data and internal mobility kind of things, social distancing. And also we looked at the sequence of testing, that how do you really test sequence depending on risk of different subpopulations within the university, right? So we built this dynamics, and we built a set of equations which is what we first do, right, when we face a problem. But then we looked at data. We said, let's look at data. And we kind of tried to look at how does reopening of universities matter in terms of infection from outside, but not just from infection from outside, but also reopening of universities can lead to increase in infection in the location where these universities are located, right? So we collected data on 85 universities. Actually, we collected data on 140 universities, but we used 85 because the rest of the data was not very sparse. So this is a graph which shows the kind of a dependence correlation between the university infectivities for all these 85 universities and the counties where these universities are located. And you will see that there is quite a bit of conformance in the surges. When the universities surge, the counties also surge in terms of the infection. Now, obviously, this is not a one-way causality. It's both ways dependent, right? Both are interdependent on each other. And also we saw that, okay, weekly testing positivity, so the test positivity of the universities, and if we look at the active cases in the population in the county, there's a strong correlation, right? So this motivated us to say that, okay, let's understand through, because we cannot use just average equations, so let's understand through a agent-based simulation, and pretty much the same thing that Shield, Illinois also did, right? So agent-based simulation, what are the right testing ratios, right? Obviously, there is no one right testing ratio. Like testing ratio is how many tests you conduct per week divided by the population of the university, right? So there's no one right testing ratio. It depends on how much you can conform to mask wearing, how much you can conform to social distancing, and it is a dynamic thing, and it has to be adaptive in nature. You need to adapt to the emerging positivity that you observe from the past testing. So in a way, testing acts both as a control measure as well as your eyes and ear into the university's positivity and the population, right? And how do you combine these two? So we did this simulation. We came up with several scenarios and several ratios. So one ratio that, again, this is just a very general, it depends on the context and depends on how the positivity is, right? One ratio that struck up was 1/5, 20%. You need to test 20% of the population at least to be even close to this R naught of 1. If you want to go below, you have to do more. And obviously, this is adaptive. If there is lower conformance to mask wearing, then you need to be testing more. If there is a higher positivity or there is an emergence of a new variant, then you need to be testing more. So that's what we came up with, and this is what we showed. And this has been published in a paper in Nature Scientific Report, right? And then we also looked at other sensitivities, like what happens, how much the speed of testing matters, how fast you need the results, the sensitivity versus the speed trade-off, right? Obviously, if you have a test which is highly sensitive, that needs a lot of processing and lot of steps in between to get the results, there will be delay in getting the results. So how speed and sensitivity matters, it turns out that speed is a much more important factor than the sensitivity of the test. Obviously, there are limits to it, right? So this is something that we understood from university testing. The next thing that we did was that after university testing, that what about the schools? Obviously, the schools, K-12 schools, opened up much later than the universities opened up, right? At least 1 semester later, right? And there has been a lot of social and psychological effect of schools closing down, economic effect also, right? So it's to the best benefit of everybody that the schools should open, and CDC promoted this test to stay program, and now this test to stay program has been implemented through the Shield Illinois project in around 1900 schools, I think. If I'm not wrong with the number, but we use data from around 500 schools. We did collect data from many different schools, but we could use only 500 school data, and we tried to see that, does it help to test? How are the schools safe? And it's the same kind of analysis, and it turned out that this can be implemented in 2 different policies, opt-in versus opt-out. And we looked at media, we looked at some of the media reports, and we saw that, okay, there has been a lot of debate on opt-in versus opt-out. Some groups wanted the opt-in, some groups wanted the opt-out. So what opt-in means is that you will be not tested unless you voluntarily opt in into the program, and what opt-out means is that you will be tested by default unless you voluntarily opt out of the program. Obviously, both the policies give everybody the opportunity to test or not to test. However, is there a difference between the two, and why are these 2 groups debating, and can we add to this debate, right? So we collected this data, and I looked at opt-in versus opt-out. So the red one is the opt-in, and the green one is the opt-out curves. And if you see this, in opt-out, there's a significantly higher number of testing done, right? And in opt-in, there's a significantly lower number of testing done. And when we looked at the cumulative test positivity, it's just the reverse. In opt-in, the test positivity in the schools is significantly high, and in opt-out, the test positivity is significantly low. Now, this is a descriptive graph. This tells us that there is at least some difference between these 2 policies. It's not a causal analysis, it's not causality. However, we can at least say that there is some difference, and why this difference occurs is important. So we also looked at school types, elementary, middle school, high school, and we looked, and the pattern pretty much stands out the same way in both these, in all these school types and the locations, metropolitan versus non-metropolitan locations, right? So we try to understand why this difference in positivity between these 2, and why the difference in testing between these 2 school groups, opt-in versus opt-out, right? So we looked at behavioral theory, that mass behavior. There is this behavioral theory which looks at status quo bias, right? So we think that status quo bias probably plays at least some role in this testing behavior, right? Most people in their judgment, in their decisions, exhibit some judgment and decision biases, and this is one bias that crops out here. And the outcome on positivity is entirely mediated by the testing rates, Because opt-in schools test less, the positivity is higher, and because opt-out schools test more, the positivity is lower. So we try to add to this debate from a very data and objective perspective, and this is a match sample causal analysis. I'll not go into the details of how we did this analysis, but this shows the same results, right? So this is what we did, and this paper we are also submitting now. And I'll hand over to Bose, who will take the next two things.
Thanks, Ujjal, and thanks, Sridhar. So when we started looking at COVID-19 research, so we're a bunch of my colleagues here are from the business school, and I'm sort of the odd man out. I was from the Granger College of Engineering. I work in power systems, has no connection to COVID-19 research except got COVID once. The idea was, so what I do, I work on sort of mathematical modeling, and we are decision makers. So that's what I like to think of myself as. So optimizing decision making in various contexts is what I want to do. So COVID was one example of a situation in a context where you can think about the analysis as well as control, right? And so the two pieces of our work that Ujjal presented was in terms of a small population, right? Of a school, of a university, and a little bit more into the location of the towns where these universities and schools are located in. But where we first began, we were trying to look at things in the sort of the large population regime, because that's where all the compartmental models, the mathematical models for epidemic spreads are sort of developed for. And so that's where we started. So I wanted to quickly share a little bit of the results that we got there. So the first piece is on the Delta variant's emergence, right? So there was this nice ad that I found on Google. It's not on the slide yet anymore. It is suspected in like around January 2021, where it was suspected that Delta variant might become the biggest or the most dominant strain of COVID-19. Well, actually, it is there on the next slide. So, but before that. So this is, we are in around 2021, summer, and we're looking at the data. What caused the wave of COVID-19, and why did Delta rise so fast, and why did we get hit by it? This is the time when we thought COVID was over. I went on a vacation, 2021 summer. Why? Because things, I was at home, depressed for 1 year. So wanted to get out. The first chance we got vaccinated. The world was opening up back again. But things closed down again, unfortunately, right? What hit us? Why did it hit us? So what we did was we took some data from India, where it first began, the Delta variant, and started to look at it and try to fit a classic diffusion model. Everybody has looked at some compartmental model of epidemic who has worked in the space. Right? We try to fit it and look at those red circles, the regression errors, or in other words, our model was a bad fit. What does it indicate? That the assumptions under which the model is predicated, those premises are wrong. Something is amiss. So the data within India, so this is some reasonable model of a compartmental model of variation of COVID. We know a little bit about its transmittivity rates and so on. This is 1 year in, or 1.5 years in already, into the disease. So we knew a little bit at this point, right? And yet, this regression error is completely, for the lack of a better phrase, out of whack. Why? So we've suspected that possibly, if you look at the graph that is below in the middle, that the number of districts that are getting affected by COVID-19, the weekly positivity rates, etc., those are rising extremely fast during the second wave in India, which indicates if something is hitting too fast, this is probably a result of a super spreader. This is a shock. This is not a diffusion. So rather than thinking about all transmissions of COVID-19 or any other epidemic or pandemic as just a diffusion process, we must think about shocks to the system. And that shock was well understood. So people suspected the Kumbh Mela that happened in India, this religious gathering of a very large number of people from all over India. You come in one place, you get COVID and you return, you become the seed of infection for that locality, right? And this is somewhat prevalent. I mean, you can see that in the data, right? And then we wanted to understand, did Delta emerge the same way in other countries? Well, there we don't really have such super spreaders, but why did US get it? Why did UK get it? And most other countries, I think it was June 2021, where it was like in 179 odd countries. I may be wrong with my numbers, but if you look at the data, it kind of shows some interesting patterns. So take the countries with high Indian diaspora versus the ones that are not. Just the higher is on the left-hand side, the ones on the right are the ones with lower Indian diaspora. And the ones on the left show that the shocks, the positivity rates or caseload is higher following India's peak. Maybe then travel is at the heart of this, right? You can look at it, a lot of this analysis was done by, back then he was a postdoc, he will be a speaker tomorrow, Sebastian Soyeris. A lot of this, the work that happened, we were like, okay, so then is this due to travel restrictions? And there is some correlation. Now, do you want to completely shut down travel? Travel restrictions have been politicized. There are socio-economic and political considerations that go into it. But you can get around it, perhaps, by testing. Testing is one of those mechanisms by which you can actually control, rather than asking everyone to not come or everyone to not travel. Why don't you selectively understand who have the potency to infect? And so bulk testing, I feel, is still at the heart of, rather than thinking about the blunt instrument of closing down, which closes down everyone, infected, uninfected, doesn't matter. Use the sharper instrument, that of testing, right? And thanks to Shield, Illinois, we have some of that. We have some of that in our state, and many other universities, etc. Tried it. I wish this happened at airports, right? So this was sort of the super spreader and Delta variant. I want to quickly finish this by going back. This is summer of 2020 when I looked at this problem. I blame Sridhar for this. As I said, I work in power systems, have nothing to do with this. He brought me in, and I had written some papers on epidemics back in my graduate school days. So when I looked at this problem, and this idea was, if you could isolate everyone with COVID-19, isolate them for a week and a half, 15 days, the disease stops, right? So why is it spreading? So must be because we are not being able to identify who have it and who don't. So there must be asymptomatic transmission. So this paper came out from, I think was published in New England Journal of Medicine on how asymptomatic transmission was at the heart of this particular, was the Achilles heel of this particular epidemic. So we tried to write a compartmental model that explicitly accounts for asymptomatic transmission, right? And so and then also thought of testing as a control tool. Don't think of it just as an eye into how much infection is happening, but rather as a muscle to enact or stop infection, right? And so we came up with our equations, of course, and what we ended up doing was to look at sort of these, whoops, is there a way to go back? There is no way to go back. Oh, yes, okay. So this classic R naught that even Martin spoke about and this reproductivity rate, the idea is, will the disease eventually disappear? So we wanted to understand, there were many chats, right? Oh, the disease will disappear even without testing, without any lockdown, and so on and so forth. Well, our analysis with some numbers show that no, there is no chance without any testing. With perfect symptomatic testing alone, without any contact tracing, you still won't be able to do much. In fact, with only perhaps perfect symptomatic testing with a fair amount of bulk random testing and some contact tracing, then there might be a chance. Then you stand a chance. Which means that a combination of these factors, now perfect contact tracing at a national scale. This is not a university. Not everyone will have an app, right? You can't do that much, a fraction of America's population being bulk tested every day. That's a much bigger challenge, right? So I don't know the answer to the problem lies in the fact that we don't have these kinds of resources, at least not at the start of an epidemic, but we did what we could. And thanks to Shield, Illinois, we've been able to do a lot within at least the university contexts. But this at a national scale is a much harder problem, okay? We did a little bit more. We thought about, can you think about the total cost of an epidemic and can you take control actions to mitigate that and minimize that cost? So you can think about, there is a death toll, there is an economic impact of lockdown, there is a healthcare cost of people who test positive that you have to take care of, and the cost of testing. And some results that we've been able to show analytically and so on, this is classic optimal control problem. I love doing such problems. But what it sort of showed is that you probably should, as early as possible when you can, lock down. Because later on, your cost overload is way higher. So do it early. But there are political, economic ramifications of such a statement. While mathematically it might be useful, there are social and other factors that go into making such decisions. Now, I would like to sort of end this. So, you know, COVID, unfortunately, I mean, I was just talking to one of my colleagues yesterday, and his family is going through COVID right now. The children had it, the wife had it, and so on. But we've largely managed it to the extent that at this point, we do bear the healthcare costs, but it's not nearly as fatal as it was in 2020, 3 years ago, right? Wow, it's 3 years ago now. And so what are the next steps? We've been doing some analysis and control for it. So the next steps that I think all of us have touched on, we've written a model with testing and asymptomatic population and their role in epidemics. What about human behavior? That plays a huge role. Think about pandemic fatigue. At some point, I was not listening to the news anymore. I was tired. And I think all of you were too, right? Yes, the first time I was vaccinated and I was allowed to travel, I did. People, when they could not wear masks or put their masks as a nice gnome beard, they did. These are factors that go into some students will party, can't stop. How does that affect the epidemic models that we use? Because without them, our models are wrong. And the disease doesn't care about the model we care about. Our model needs to take care of how we react to the disease and the disease itself. Makes sense? Second, robust supply chain management. Something that we've all faced, ICU shortages in various countries. People had to make phone calls, use their personal connections to get an ICU bed during the Delta emergence in India, right? And it was similar here. Ventilators going out of, there were not enough ventilators, not enough masks. How can we prepare for that? Can you prepare all of it? Probably not. But can you make at least some basic assumptions as to how one might manage this and take some steps? And the last bit that we sort of want to think about is not just inventory or supply chain, but think about people management, doctors, nurses. These are also operational decisions one might have to think about. There has been a shortage of nurses that has happened since the pandemic. We've listened to some of them during one of the healthcare workshops that we organized. So one needs to think about these operational decisions and how they matter as a result of an epidemic. COVID-19 and its fatalities might be a thing that we look at as an object in the past, But the kind of operational learning that we may want to take and take it forward to the next possible pandemic, it's a very interconnected world, and we want it that way. We don't want to lock ourselves down into our own rooms. That's not the goal. The goal is to connect, to learn from each other. And if that is the goal, how can we prepare better and make more operational decisions to both analyze and possibly way better control it for the next one? We didn't do a very bad job. Think about the number of deaths that happened in the world from Spanish flu a century earlier. COVID, we did a lot better. But can we do even much more based on the kind of operational capabilities we have today and the decision-making science that we are trying to create? Thank you.